Welcome to this webinar from the Supportive Care Iowa project of the Catholic Bishops of Iowa. My name is Tom Chapman, and I'm the Executive Director of the Iowa Catholic Conference. Our purpose for offering this presentation is to help those seeking guidance on making healthcare decisions in alignment with Catholic moral teaching. To help us learn more about why that's important, we're going to start with Deacon Kent Ferris. Deacon Kent is the Director of Social Action and Catholic Charities for the Diocese of Davenport. He is also a secular Franciscan. Kent?
I remember traveling with Deacon Dan Freeman to Waterloo in 2016 to attend training for advanced care directives. The information, as we will hear in today's session, was helpful not only for personal planning, but also in light of church teaching on the dignity of human life. After the session, Dan and another deacon and his wife began providing information to individuals in our diocese so that they had plans in place, known both by medical providers as well as family members. I wish I could say that I too immediately completed paperwork, but that's not the case. But last summer, I experienced a mild heart attack. The experience served as my wake-up call to have documents in order. So this summer, my wife and I met with Dan, reviewed the documents, and now have in place our durable power of attorney for healthcare. Now, when I go to the medical appointments, the medical professionals have on file that document. Now our family knows of the steps we've taken to be prepared.
Next, we have Dr. Janine Marie Ejak, who is Professor Emerita of Philosophy at Loras College. She currently serves as Chancellor and Consultant for Healthcare Ethics for the Archdiocese of Dubuque and is part of healthcare committees at the local, state, and national levels. Janine is going to cover the Church's perspective on using or foregoing life-sustaining treatments, as well as palliative care.
I would like to share with you the guidelines the Church provides to assist people with making difficult decisions about using or foregoing life-sustaining medical treatments. These are the moral guidelines you should keep in mind in executing advanced directive documents. When we talk about life-sustaining medical treatments, what do we have in mind? An example is a ventilator helping a person to breathe. Chemotherapy and radiation therapy are life-sustaining treatments for persons suffering from cancer. Kidney dialysis sustains a person's life who does not have properly functioning kidneys. Resuscitation can restore heartbeat. Tube feeding sustains the lives of persons who cannot eat in the normal way. Antibiotics, blood transfusions and blood products, and pacemakers may also serve to prolong life. These are examples of life-sustaining treatments, not an exhaustive list. Today, there is much emphasis placed on patient autonomy. This is the idea that the patient is the ultimate decision maker about medical treatments. Healthcare providers provide information about the patient's condition and about treatment options. But on this model, they should do what the patient wants. The Catholic tradition respects patient choice, but wants individual choice to be guided by sound moral principles. So let us explore the moral principles which should guide us in making decisions about using or foregoing life-sustaining treatments. You may have heard of the distinction between ordinary and extraordinary medical treatments, and the accompanying principle that ordinary treatments have to be provided, but that it is permissible to forego treatments which are extraordinary in character. This distinction goes back several centuries in the Catholic tradition, and over time, different meanings came to be attached to these terms. In the 20th century, theologians attempted to clarify what these terms mean. Our contemporary understanding of ordinary and extraordinary treatments is in terms of the benefits and burdens of a treatment. A treatment is considered ordinary if it offers a reasonable hope of benefit and does not involve any excessive burden. A treatment is considered extraordinary either if it offers no real hope of benefit or if it involves an excessive burden. Benefits of a treatment are understood in a broad sense. Obviously, a medical treatment is a benefit if it brings about the cure of a disease or condition, or at least improves the patient's condition or level of functioning. A treatment is beneficial if it relieves pain or other distressing symptoms the patient is experiencing. In a very basic sense, a treatment is beneficial if it prolongs the patient's life. Or again, a treatment is beneficial if it enables the patient to do things that are meaningful to him or her, or which give them satisfaction in life. For example, resume a hobby or participate in activities with grandchildren. A treatment is likewise beneficial if it enables the patient to fulfill specific life goals. For example, to take a trip to a particular area or to celebrate a 50th wedding anniversary. These are examples of benefits, not an exhaustive list. Similarly, burdens are also understood in a broad sense. Causing pain or substantial discomfort can be a burden of a treatment. For example, one can think of the side effects some people suffer from chemotherapy. A person who survives resuscitation may be left with neurological damage. Such debilitating or disabling effects are a potential burden of CPR. Or again, a particular medication could have very serious and even life-threatening side effects, and these risks can be considered a burdensome aspect of the treatment. Burdens can also be psychological. For example, the depression that can affect a patient undergoing prolonged kidney dialysis. Difficulty in getting access to a treatment can also be a burdensome aspect of it. For example, the very driving distance to get to a dialysis center. The Catholic tradition also allows us to take the high cost of a treatment into account in evaluating burdens. Again, these are examples of treatment burdens, not an exhaustive list. The first principle for making decisions about using or foregoing life-sustaining treatments is that we do have a moral obligation to undertake medical treatments which offer a reasonable hope of benefit without being accompanied by any excessive burden. Consider the case of Jeremy. Jeremy is 78 and resides at Red Oaks, an assisted living facility. He still participates in many activities for the residents. However, he has recently developed pneumonia. His doctor recommends hospitalization with antibiotics and supplemental oxygen. The doctor thinks Jeremy's prognosis is good if he does this. However, Jeremy has been a very independent person all his life. He tells the staff that he feels very comfortable in his apartment and just doesn't feel like picking up and going to a sterile hospital. Jeremy's two sons don't agree with their dad and try to persuade him to go to the hospital for treatment. From a moral point of view, we can ask the question, would it be permissible for Jeremy to refuse the recommended treatment for his pneumonia? From a moral point of view, Jeremy should undertake the recommended treatment. The treatment is of clear benefit to Jeremy. His prognosis is good if he undertakes it. There is inconvenience in temporarily leaving his apartment and going to the hospital, but this cannot be considered an excessive burden. This inconvenience is in no way comparable to the life-saving benefit of the treatment. On the other hand, it is considered morally permissible to withhold or withdraw a life-sustaining treatment that offers no real hope of benefit to the patient. A treatment can be useless or futile in the case of a particular patient. It is also considered morally permissible to withhold or withdraw a life-sustaining treatment that is excessively burdensome for the patient. This is often understood in terms of the burdens of a treatment outweighing the benefits. And who makes the assessment of benefits and burdens? This is the prerogative of the patient or his or her proxy decision maker. To better understand these principles, let us consider some examples. Marta, 85, still lives at home. For some years, she has suffered from a heart condition, which is getting progressively worse. She knows that someday her heart will just give out. She has also dealt with 2 bouts of serious pneumonia in the last 6 months. Marta says she is ready to go home to God. Marta's daughter, who is a nurse, suggests that she get a do not resuscitate order. When Marta and her daughter raise this issue with Marta's physician, the physician comments resuscitation probably would not even work for her because of her underlying physical problems. From a moral point of view, is it permissible for Marta to have a DNR order written? The answer is yes, it is morally permissible in this case, because the resuscitation procedure is not likely to work to revive Marta. It would be a futile procedure offering no real benefit. Our third case concerns Jack, who is 62 and who has been on kidney dialysis for 3 years. He has recently told his children that he wants to stop going to dialysis because he's sick of it. Initially, Jack had tolerated the dialysis well, but within the last several months, he has been experiencing serious side effects and complications. His blood pressure drops sharply after dialysis, and sometimes he faints. He is having problems with nausea and vomiting and with muscle cramps. Occasionally, he suffers a temporary loss of vision. He is also experiencing some bleeding problems from the blood-thinning medications used during dialysis. From a moral point of view, is it permissible to stop the dialysis treatment as Jack wants? The answer is yes, because the effects of the treatment are a significant burden for him. According to the benefits and burdens principle that we have been using, there is no treatment that must automatically be used. Similarly, there is no treatment that can automatically be forgone. Rather, decisions must be made on a case-by-case basis. One must ask the question, what will this treatment do for this particular patient who is in this particular condition? Who judges the benefits and burdens of a treatment? This falls to the patient, but the judgment should not be made off the cuff. The assessment of benefits and burdens must be well informed factually and well thought out. If the patient is incapacitated and cannot make this judgment, the assessment of benefits and burdens of the treatment falls to a proxy decision maker, who should adopt the perspective of the patient and assess the benefits and burdens as the patient would judge them. At one time, some people believed that one could withhold the treatment, but that once started, it was not permissible to stop it. This kind of thinking has changed. Both ethically and legally, it is considered just as permissible to withdraw treatment as never to start it. In some cases, it is not clear whether treatment will benefit a particular patient or not. If one has the mindset, once I start a treatment, it cannot be stopped, one may be afraid to have the treatment started for fear of locking someone into a treatment that is not beneficial. But that may mean that some patients who could have benefited lose out. What is recommended today is a time-limited trial. If one is not sure whether treatment will benefit a patient, use it for agreed-upon period of time, and then evaluate how the treatment is going. If it is working to benefit the patient, continue it. However, if the treatment proves non-beneficial or burdensome, it may be stopped. But at least one has given the patient the opportunity to benefit from the treatment. Emotionally, it may be more difficult to stop a treatment than never to start it, but withdrawal is permissible both ethically and legally. Our last example concerns medically assisted nutrition and hydration, more commonly known as tube feeding. This is something of a special case in terms of church teaching. In the eyes of the church, the provision of food and water, even by medical means, is considered part of the normal care due to the sick person. Therefore, in principle, we have an obligation to provide medically assisted nutrition and hydration to patients in need of it. This is different from such treatments as ventilators, chemotherapy, and dialysis, which are not considered part of normal care. However, it is considered morally permissible to withhold or withdraw medically assisted nutrition and hydration if it cannot reasonably be expected to prolong the patient's life. In other words, if the procedure just won't work in the case of a particular patient. Going back to the principle of benefits and burdens, the procedure will not provide the patient the benefit of prolonging his or her life. For example, a patient may be suffering from such severe heart or kidney failure that their body cannot process the nutrients or fluids supplied through the feeding device. Or again, it is considered morally permissible to forego medically assisted nutrition and hydration if the procedure would be excessively burdensome for the patient or cause the patient significant physical discomfort. For example, use of a feeding tube can bring about diarrhea, nausea, vomiting, or even aspiration pneumonia. As a general rule, it is not morally obligatory to provide medically assisted nutrition and hydration to someone who is imminently dying. In such circumstances, this treatment has very limited ability to prolong life, and there is evidence that patients who are allowed to die without it may die more comfortably than patients who receive conventional amounts of intravenous hydration. Because church teaching about medically assisted nutrition and hydration is complex, one must be very careful in giving directives about it in writing advanced directive documents. We now want to turn consideration of pain management and palliative care. Palliative care aims to improve a patient's quality of life by managing pain and other distressing symptoms. Providing palliative care involves a team of professionals, physicians and nurses, mental health professionals, social workers and chaplains, physical, occupational, and speech therapists, and perhaps other types of health professionals as well. Palliative care is a central part of hospice care, but it is not limited to hospice. Palliative care can be provided to patients with chronic illnesses and for a number of years, and to patients still seeking restorative and curative treatments. Perhaps you grew up with the religious idea, as I did, that when it comes to pain, one should just tough it out and offer it up. However, the thinking of the church has evolved. Now there is an endorsement of good pain management. Regarding pain and suffering at the end of life specifically, the ethical and religious directives for Catholic healthcare services tells us that one of the primary purposes of medicine in caring for the dying is the relief of pain and the suffering caused by it. Effective management of pain in all its forms is critical in the appropriate care of the dying. This change in attitude may be related to the recognition that experiencing pain and other distressing symptoms prevents people from engaging in important and meaningful activities. As an illustration, I'd like to share with you comments made by Cardinal Joseph Bernardin in his book, The Gift of Peace, regarding his surgery for cancer. Quote, "I spent only one night in the intensive care unit. Then they brought me back to my own room, where I experienced the discomforts one normally encounters after going through extensive surgery. I wanted to pray, but the physical discomfort was overwhelming. I remember saying to the friends who visited me, pray while you are well, because if you wait until you're sick, you might not be able to do it. They looked at me astonished. I said, I'm in so much discomfort that I can't focus on prayer. My faith is still present. There is nothing wrong with my faith, but in terms of prayer, I'm just too preoccupied with the pain. Since good pain management is so important, I'd like to address some concerns about it. In the past, there has been concern that providing narcotic medication to dying patients will depress their respiration and hasten death, thus engaging in an act of euthanasia. Traditionally, the administration of pain medication in these circumstances has been justified morally by something called the principle of double effect. The intent is good, to relieve pain, and the depression of respiration and hastening death is an indirect side effect of that good action. However, there has been a trend in the more recent medical literature to downplay the potential for pain medication to hasten death. In fact, there is evidence that administering narcotic medication in amounts sufficient to provide adequate pain relief may extend rather than shorten life. This is because patients without pain are more likely to eat better, to be more active and less depressed, and to be more open to other treatment possibilities, all of which results in their living longer. I'd also like to address the special case of what is called palliative sedation, which is the use of sedating medications to relieve pain or other distressing symptoms, which the patient cannot tolerate, after all other measures have failed, and this qualification is important. The medications are expected to reduce the patient's level of consciousness. The degree of sedation needed to make the patient comfortable will range from light to moderate, and in extreme cases may require sedation to the point of unconsciousness. Going back to Pope Pius XII, the Church has recognized the moral permissibility of palliative sedation, but cautions that the patient should have had the opportunity while fully conscious to prepare spiritually for death, for example, by receiving the sacraments, and to fulfill moral and familial obligations, such as reconciling with estranged family members. I would like to close this segment with the words of Pope Francis in an address to the Pontifical Academy for Life, quote, "Palliative care is an expression of the truly human attitude of taking care of one another, especially of those who suffer. It is a testimony that the human person is always precious, even if marked by illness and old age."
We will now turn to the advanced directive documents themselves. There are basically two types of these documents, the living will and the durable power of attorney for healthcare. We do not recommend using Iowa's standard living will form because it's not totally in accord with church teaching on the issue of medically assisted hydration and nutrition. Rather, we recommend use of the durable power of attorney for healthcare. Deacon Dan Freeman will walk you through a durable power of attorney for healthcare packet that was developed by the Medical Moral Commission of the Archdiocese of Dubuque. It includes addenda which present choices for care which are formulated in line with church teaching and address different stages of one's lifespan. Deacon Dan will also discuss iPost, an advanced care planning document specifically for persons with a terminal illness, a chronic critical medical condition, and the frail elderly. Deacon Dan was ordained to the permanent diaconate in July of 2017. He received training as a Catholic advanced care planning consultant in November of 2017 and is currently serving as parish life coordinator at St. Mary Catholic Church in Wilton, Iowa.
The durable power of attorney for healthcare provides, first of all, a Christian affirmation of life. The procedures and ideas listed in this document affirm church teaching and allow a person to select which types of care that they are interested in. So on the second page of this document, we actually, instead of designating in the Iowa Living Will the attending physician, we designate someone who actually understands and knows what our desires and wishes are. So we appoint this person as our attorney for healthcare decisions, and we list their information. And we acknowledge that this power exists only when I am unable, in the judgment of my attending physician, to make those healthcare decisions, and in fact must act consistently with my desires as stated in this document. So the lower paragraph then makes the statement to make healthcare decisions on my behalf. And important in this regard is to consent, to refuse to consent, or in some cases, as Janine pointed out, to withdraw consent of any care, treatment, or service or procedure to maintain, diagnose, or treat any condition. And this power of attorney would have this obligation to follow your wishes. At the bottom of the page then indicates where we can state those specific wishes and desires that we want to put in place and that we want our attorney for healthcare decisions to follow. And we'll talk about these addendums a little bit later. It's also on the second page important to designate an alternative. Our attorney for healthcare decisions may not be available. Maybe they've passed on. Whatever the case may be, it's important to have a second who also is familiar with your wishes and desires related to your healthcare decisions. And so you indicate their information on this. This is signed, and you would have the notary public sign at the bottom of the page, or on the next page is a location for statement of two witnesses, which would then make this a legal and binding document. The 5th, 6th, and 7th page of this gets into important terms and definitions that is important to understand. What is healthcare and healthcare provider? The witnesses that you may use. Number 3, the attorney in fact. What does that mean? On the next page, number 4, how to revoke this particular document or other documents. Number 5, prohibited practices. So only certain people should be named as attorneys for healthcare decision-making. And number 6 is most important. We need to notify others of this document. We need to notify our healthcare providers. Of course, the attorneys for our healthcare decisions, the alternates, and most importantly, any family members that may be around that would make note of this too. So now let's take a look at the optional addendums. And there are 4 of them. They are, first of all, one for women of childbearing age. Second, persons are healthy or well-managed medical conditions in the event of an unexpected healthcare crisis. Number 3, persons with serious chronic condition and or progressively debilitating condition. Or number 4, addendum, persons with terminal illness or in the last year of life. So we're going to start with the 4th addendum because it's most comprehensive. So as we look at this and you see the title highlighted, you see 2 things. The directives are specifically provided for CPR, assisted nutrition, hydration, and other types of healthcare interventions that will be identified. So here I can specifically state my wishes and my desires regarding, and again, remember this is when a person is terminal illness or maybe in the last year of life. So what do I want my healthcare decision maker to do regarding CPR under number 1? Either I do not want CPR if my heart stops or my breathing starts. I just want to let it progress as a natural part of dying. Or I want CPR until I'm able to achieve certain life goals. And I'm going to list those. And maybe it's the sacrament of the last rites, or perhaps it's talking with family one last time. And then I indicate after I've achieved those, then I do not want CPR after that fact. Or the third indication, I always want CPR. So it depends on, again, what you want to decide. The same thing on page 2, assisted nutrition and hydration. As Janine mentioned, tube feeding. So it should be used when there's a need for it. However, it should be withheld or withdrawn if I cannot reasonably be expected to prolong my life, especially excessively burdensome or cause significant physical pain. So I can choose that option, or I can choose to use it indefinitely when I have need of it, as long as it provides nourishment to my body. Number 3, we list other types of healthcare interventions that have been mentioned before. And under each one, we list those treatments that will be beneficial to me, that are important to me, or the types of treatment that are burdensome to me, that I'm concerned about, that I don't want. And again, it's important to indicate those, or indicate that I want all available healthcare interventions used to treat my condition. The next page, we talk about pain management, and you heard that discussed. So we have 3 options. Relieve my pain as much as possible, even if I'm drowsy or sleepy. Or I want to remain awake and alert and endure some degree of pain or discomfort because I want opportunity to carry out duties and relationships or prepare spiritually to die. But if the pain becomes severe, then I want it relieved. Or option 3, I always want to remain alert and awake as much as possible, even though I have pain and discomfort. So in each case, we're given options that we can select. Section 2 then identifies when I am actively dying. I do not want CPR, or I want it until I'm able to say that last goodbye, and then I don't want CPR, or I always want CPR. On the next page, the assisted nutrition and hydration, the tube feeding. Again, I want to forgo it, or I want it until the time of my death, provided it will succeed in providing nourishment to me. And then we identify other types of healthcare preventions. Either I do not want them, or I want them all. Again, we're in the last stages of actively dying. And the last one, number 4, pain management. Again, the 3 levels. During that time of actively dying, relieve my pain as much as possible, even though I may be sleepy or drowsy. Allow some degree of pain and discomfort because I want to complete those last obligations I feel. Or the third, I always want to remain awake and alert, even though I have some pain and discomfort. So each one has a level of indication that I should select. So let's look at one of the other addendums then. Again, remembering that that one was for those facing terminal illness or who may well be in the last year of life. The next one we'll look at is for a serious chronic condition or progressively debilitating condition. And here we have the same choices. We see the directives, we see the generic terminology for other types of healthcare interventions. But let's look at our wishes, because they become in large part, they are the same choices that we faced in the first addendum. I do not want CPR. I want CPR until I'm able to achieve life's goals, and then I don't want it. Or option 3, I always want it. The next section on page 2, we see the same choice that we saw in the first addendum, either to withhold it or withdraw it, or to use it indefinitely. And then other types of healthcare interventions. Again, we look at the benefits and or burdens. We want to list those, or I want all healthcare interventions. And we have to remember that we are providing direction to our attorney for healthcare decisions. The last page then goes into pain management and is the same verbiage that we saw in the first addendum for those that are actively dying or terminal illness in the last year. The next addendum is for those individuals who are healthy, have well-managed medical conditions, and may have an unexpected healthcare crisis. So our healthcare interventions are listed a little bit more in depth because we're typically healthy. As some of the examples that Janine used, we may take blood transfusions that may restore us to the health that we had before. But again, as far as the wishes and desires, we start with healthcare interventions under number 1. I want everything, or I only want that which offers a reasonable hope of benefiting me or contributing to my comfort. And I do not want healthcare interventions which are not likely to be beneficial or burdensome. And we've defined those terms. But we're going to list those types of treatments which we feel would be beneficial to me to prolong my life if I would be dying all of a sudden, to do those last end-of-life things, or those types of treatments that I just considered too burdensome, whether they be so extremely costly, place a burden on my family, or cause me severe pain and discomfort. Number 2, we talk again about the medically assisted nutrition and hydration, the tube feeding. The 2 options to be used as long as it provides nourishment, or to be withheld if it's not reasonably expected to prolong my life, would be excessively burdensome, would cause significant physical discomfort. So we can use those 3 addendums to determine where we're at in our healthcare, in the health that we are currently at. The last addendum that we need to look at is for women of childbearing age. So there are 3 situations that a woman, according to the Catholic Church, would want to look at and consider. And the main issue here is if I should suffer brain death while pregnant. I wish my body to be given medical support to allow the pregnancy to continue as long as there is a reasonable possibility that the child could develop to the point of live birth. Okay. The second option, and these aren't options, these are statements based on Catholic Church teachings. Also, if I should suffer brain death while pregnant, I want medical support not to be given to my body if there's a reasonable degree of medical certainty the child would not develop to the point of live birth, and the child should be allowed to die naturally in my body. And the third condition, medical support of my body should be stopped if it becomes clear to a reasonable degree of medical certainty that the child would not develop to the point of live birth through such medical support of my body. and that the child may be allowed to die naturally in my body. So these options, these forms, I think show importantly also with what you've heard from Janine and Kent, why it's important to designate a person who knows our wishes and desires, who will carry them out, and where we have indicated especially that we want to adhere to church teachings in regard to our healthcare decision making. The last form that we want to go over is the IPOST. The IPOST stands for the Iowa Physicians' Orders for Scope of Treatment. And this form is filled out by a healthcare professional with you or with your designated attorney for healthcare decision. And this takes the durable power of attorney, the healthcare decisions, your wishes and desires, and puts them on a form that medical professionals will use. So in A, we check about CPR. What are our desires in the form? They will be placed on this form. Under medical interventions, the comfort measures only, and perhaps an indication of no transfer orders, or the limited additional interventions or full treatment are indicated based on what we've indicated in the addendums. The same thing with the artificially administered nutrition, the tube feeding, the three options there. Then section D, we indicate where these decisions came from. And in our case, if we are awake and conscious and capable, then they come from us. If we are not, then our durable power of attorney for healthcare takes precedent, and our attorney, in fact, would make these decisions, and it would be indicated on this form. And on the right hand of the form, you see where the decisions have come from. The form is signed off by a medical professional. And then on the second page of the form, it indicates these are our preferences for life-sustaining treatment in our current state of health. These can be renewed and reviewed anytime things change, if we are, again, capable of making decisions, or if our health condition deteriorates and we need to move to a different level. So they can be changed at any time. Down below, under voided, they can be voided and a new IPOST created. One of the things important about this form is that this form is to accompany the person upon transfer. So if we're at one medical facility and we're to be transferred to another, a nursing home, to a hospital, or emergency care, this form should go along with this so that whoever is next to treat us understands what is our wishes and desires. Any questions regarding these forms or the specific information? Contact information will be at the end of this video.
If you would like some assistance, as Deacon Dan said, in putting together a document, please let me know, and I'll put you in contact with someone who can help you free of charge. This is coming to you from the Iowa Catholic Conference. You can just email me at this email address. You can also call this number and get me a message, and we will help you, talk to the people that you need to talk to help put these documents together. We really encourage you, if you don't have one, to start working on one. Don't hesitate to reach out to us. Thank you very much for watching this presentation.